Welcome to the STS conference in San Diego. I'm very excited to be here today with this panel. My name is Jill Lay. I'm the clinical nurse specialist for cardiac surgery at California Pacific Medical Center in San Francisco. I'm also a clinical professor in the Department of Physiological Nursing at the University of California, San Francisco. And I'm joined here today to talk about how we manage cardiac arrest in the United States. My panelists are Joel Dunning, a cardiothoracic surgeon from Middleborough and chairman of the STS Guideline Development Committee. I'm also joined by John Whitlock, who's the clinical nurse specialist for cardiac surgery at Beth Israel Deaconess Hospital in Boston, and they've just completed their protocol approximately 2.5 years ago. And last is David Lizotte. David is president of the APA-CVS organization, as well as a physician assistant at the University of Louisville Medical Center in Kentucky. And so we're very excited to be joining you today to talk about this important topic. I'd like to begin with Joel. Joel, can you describe for us the problem in the way that we've currently been managing arrests without this guideline and how you started this course?
Thank you. I was a trainee surgeon in the UK in 2003, and I just came from my medical wards where I'd learnt my resuscitation protocols, and I used to rush to arrest, and I used to love them because you'd go there and these people, you'd drag them, you'd do some massage, and you know, they might not even make it, but you'd feel proud in yourself that you'd done a great job for these people because you worked as a team. So I was quite looking forward to emergencies in cardiac surgery, but my first arrest was absolute mayhem. People didn't know what to do, there was no direction, and the person arrested 3 times. I ended up taking a piece of vein on the intensive care bed, and I think we were all scarred from that. And I asked some of the nurses around me, God, it must get better with experience, and they said it never gets better. So it struck me that what is different between the medical arrest that I was very comfortable in and the cardiac surgery, post-surgery arrests where I was so uncomfortable, and the answer was a protocol. The answer was getting together, training, and learning how to do this as a team.
Absolutely. I see some heads nodding down there. David, could you tell us how you've implemented this at your facility and also how the APA-CVS has gotten involved?
Yes, thank you. It's also a pleasure to be here. I've been a cardiac surgery PA now for 21 years, and one of the most challenging things you face as a PA in cardiac surgery is the realization that you might be the first person on the scene for a patient who is arresting, and contending with the realization that you may be opening a chest by yourself while you're waiting for your surgeon to arise. I think one of the great things about this protocol is that it helps all of those people who are helping you while you're working towards opening the chest and saving a patient's life. With regards to the APA-CVS, we became sort of in tune with the CALS training by inviting you actually to speak at our course a couple of years ago. And what we recognized was that this was an incredibly valuable training for physician assistants in cardiac surgery, and that we could not only learn from the protocols, but also we could be integral in teaching these protocols to other people. So we were very much early adopters of this training in this country, and now we're anxious to teach this to everybody in cardiac surgery in the United States.
Great. And John, can you tell us how your organization got started with this? It sounds like you've made a lot of progress.
We have, and we've done a lot quite quickly, actually. Thank you both again for inviting me to speak. My personal experience for 25 years in cardiac surgery is that there's been an overarching frustration with the way we deal with cardiac surgery emergencies, because there's a lack of clarity in roles and a variation in training from center to center. Some centers actually don't even offer training. So this was something that was near and dear to my heart, and when I transferred to Beth Israel Deaconess in 2012, shortly after that, we had an unfortunate patient experience in which the team had misdiagnosed a shockable rhythm because the patient was being paced and had underlying VFib, and if we had thought to turn off the pacer, we might have recognized that earlier, but the patient didn't survive. Coincidentally, one of our nurses had attended one of your early programs at NTI and was able to talk about this new training that was available. So we had a small group of bedside nurses that were pretty passionate about this from the beginning, and the nurse manager of our unit, Margie Serrano, and I tried to make this happen for them. So it took off fairly quickly because it had a lot of grassroots support.
Excellent. We found the same thing at our facility. Joel, I'd like to ask you what's happening right now with this in a bigger picture in terms of a guideline that might be coming to the United States.
Yeah, well, you came to the UK, you brought the course across to the USA, and you set up a very successful training program here that's spreading. And you took it to a lot of AACN conferences, and there we met a huge number of nurses that I think a lot of surgeons wouldn't realize this, that how uncomfortable their staff feel in a rest. They think that, you know, they get there and they fix it all, it's fine. But actually, the allied health professionals really are crying out for direction and for a protocol and to know what to do, because they want to do it, they've got the skills to do it, but so far there was nothing they've got in the training. And in those courses, you know, every day we were hearing nurses that saying, you know, I shouted down the phone to try and open the chest from my surgeon coming in, and we just didn't find that acceptable. But I've been delighted by the way that we've been received in the US, and the STS have been particularly receptive to the need to change the way we do this, and the need to work as a multidisciplinary group of nurses, PAs, anesthesiologists, and surgeons. So we've got together an STS guidelines workforce with yourself and David and many other people. We have anesthesiologists, we have intensivists and surgeons, and we're very far down the track with creating an STS guideline to totally manage every element of resuscitation after cardiac surgery. We've actually already written a full EACTS European guideline, but we do want to make this specific. So I think within 6 months and maybe even less, we will have a fully accredited Society of Thoracic Surgery guideline on this area that people will then have complete sort of confidence that they will be able to follow that, and they will be supported when they follow that.
Absolutely. This is very exciting. I'll back up just a bit and tell you how I got involved in this. 2009, we had an arrest in our unit. It was a VF arrest, easily shockable. Unfortunately, someone had given the patient a full milligram of epinephrine following ACLS guidelines, and as soon as the patient was defibrillated, the epinephrine took effect, the blood pressure went to 360, and we promptly had to open the patient's chest for bleeding. I had a very unhappy surgeon on my hands, and at that point, we investigated the literature and found Joel's program in the United Kingdom. So it was in 2009 that I went there and took the course. It was outstanding, hands-on, a very streamlined approach that anyone could follow, simplified. Having tried to teach this for the last 25 years, it was music to my ears. So came back to the United States and had the opportunity to present it at the American Association of Critical Care Nurses National Teaching Institute. And from then on, it's just been really a grassroots effort. We've had centers like John's come and train with us. I've had the opportunity to speak before David's group, and every provider that hears this message embraces it. It's just very common sense, very straightforward, and we're really, really pleased to see that it's taken off. I believe with the guideline being published, that will really push us in the direction of where we need to go. A lot of centers are reluctant to do this right now because they're concerned that they're not following the American Heart Association's ACLS guidelines. So clearly there's a nice evidence base to say that this is the preferred approach. We're really getting a lot of groundswell around the United States. There are hundreds of centers that are already doing this, although I can't tell you exactly how many. So John, could you talk to me about the implementation process and what that was like as you were actually kicking this off in your own organization?
Well, we were very lucky at Beth Israel Deaconess Medical Center because we have a very supportive chief cardiac surgeon. So although all pieces of the protocol might not have been something that he was totally comfortable with, he was very supportive of the nurse managers and my desire to roll the program out, understanding that we had full responsibility for things that he didn't like, and actually it all turned out well. We took a different approach than some centers in that we realized we really wanted our team to understand that this was a new day in town. So we had a big kickoff with the entire team. There was 40 members of the team that included mid-levels and surgeons, intensivists, and nurses. That was a full-day course, and we made it clear that this was how we were going to do things from now on. Almost immediately it caught on, and people that weren't able to attend that first training were requesting to attend future trainings. We also, of course, had to get buy-in from the governing bodies of the hospital. So particularly our code committee, we approached and had several meetings with them about help them understand what we were trying to do and how it would affect not so many other people, but just us, and finally got their support. So that's how we started, and I found in my experience that things just tended to kind of roll naturally after that. The real take home is once you have a good experience on the unit, everybody has buy-in. So then everybody was interested in it.
Absolutely. We found a very similar thing. Our Code Blue committee was one of our biggest obstacles. Our surgeons were absolutely on board from the very beginning. And David, I realized when I came and presented to your organization that the partnership with the physician's assistants was absolutely a perfect match. You guys are often the first responders for these events. A lot of responsibility rests on your shoulders. And as you said, you could be faced with a lot of providers that have no idea how to help you. And so that's where I was coming from, is I've got all these nurses who may never do this or do it once very, very infrequently. And so the idea of partnering with your group made perfect sense. So could you talk to us about how maybe some of your personal experiences in kicking this off, and then about the organizational response to this?
Sure. I think that me personally, what I've found is that this training answers a lot of the challenges that I've had in my own personal practice. As I said earlier, I'm often the first person on the scene of an emergency, and it's very automatic for us to put on gown and garb and start to take care of the patient. And as we look around, we see that people are there and wanting to help, but just really don't know how to help. And the wonderful thing that the protocol does is it provides a team approach. It's very clear on roles, and clearly improves outcome for patients who are resting after cardiac surgery. From the point of view of the association, one of the things that sort of pleasantly surprised me was just how eager physician assistants are to receive this education. It's clearly become the most popular and highest rated education that we offer at our meetings, and a lot of it has to do with the personality and energy of the European physicians who come over and provide this education. But also too, I think it really just makes sense to the physician assistants. It answers some of their concerns and needs that they have in their practice. And so as an association, it's our intention to bring all of our resources to bear to bring this education to all 1,200 cardiac surgery programs in the United States. The challenges of that are obvious. People who practice in cardiac surgery are very busy professionals, and it's hard to get them to come to a meeting. So we have been offering provider courses at our meetings that have sold out at every meeting. We started offering train the trainer courses, and we've created the infrastructure to start offering this training at hospital programs, so that we come in with a team and with the equipment and provide one-day courses for staff at hospitals, so that we can hopefully have very quick and wide adoption of the protocols in the U.S.
I think that'll be really important as we see the guideline released. People are going to want this training, and so that's wonderful that we'll know where we can go for that. John, I think you've published some information about staff responses to implementing this program. I'm very interested in hearing what you found.
Well, we've actually done some poster presentation on our initial work. Because the N is so small here, we weren't really able we weren't even thinking about how we could correlate this to outcomes yet, as you have, Jill. But what I realized the staff were most concerned about, and surgeons, was the confidence level of the staff in dealing with cardiac surgery emergencies in general. But I kind of focused on the open chest arrest scenario because it tends to be the most anxiety-provoking, little the sexiest. So we did a pre and post survey with our training, a pre-survey before we did the training, and then a year after we did the training, our survey with the same staff. And with about a 70% response rate, we found that staff that had been able to rate their level of confidence as high or very high in open chest arrest jumped from 13% pre to 66% post. And more importantly, I think, from my nursing staff, the amount of staff that were able to rate themselves as moderately confident in a open chest arrest jumped from 56 to 96%. So we were very pleased with those initial results, and we'll continue to follow that over the years.
That's outstanding. And as a nurse who's been in these experiences, it is very anxiety provoking. So to have staff that feel confident in our scariest event is really amazing. We took another approach in terms of the literature with this, and we're very excited. We've implemented this program fully in 2010. So we just at this meeting have done a comparison of the 4 years before we implemented this program and the 4 years after in terms of outcomes, survival, and we sort of flipped the survival around and looked at our failure to rescue rate in patients who did suffer these events. And what we found that we were delighted to find is a statistically significant reduction in mortality and failure to rescue in the 4 years since we've implemented this program versus the 4 years before that. And the last 2 years, since we've been doing this now for 4 years, our survival rate is 75 to 85% after these arrests. And there's very few benchmark data. We're just starting to see some good studies with benchmarks, and no one is really reporting achievement that high. And we completely attribute it to this fantastic program, to a team approach where people really know what the expectations are. They walk into the room without anyone telling them what to do. They know their roles, they know where to go, they know how to contribute. And as David said, everyone wants to help in these events, but often we haven't really known how. And I will honestly say, before we had this program, it was the scariest thing that could happen. People would dread it. They would do anything on earth but open a chest. That was the last thing we wanted to do, and oftentimes it happened when it was far too late. And that paradigm has completely shifted, and we realized time is of the essence, and we've streamlined so much of the work we do to make sure that we can optimize those outcomes in a very, very important way. We're seeing dramatic improvement in survival that I believe is achievable anywhere. We don't have 24-hour surgeons, so that's one of the key things that's really important. Joel, can you talk about sort of the future of this program and where you see CALS going in the United States?
Yeah, well, you've spearheaded it so fantastically, and you really are the first person that's actually shown evidence that that you've improved mortality with this so much. So I think the future's bright. I think people really want to engage as full teams, and I think the best model is really exactly as David says: get your whole group together, and as John has already done, get your whole group together, have a day in your hospital, work together. We've got the mannequins, and we leave the mannequins behind, so you've got them forevermore in your institution, and then you just have a whole day practicing together as a team. And when you do that multiply, then when we leave, we've got you set up brilliantly to practice it from there on. So we've got the STS guidelines, we've got a good infrastructure from David, and good experience from John here that really is going to hopefully set this up for the future. And I think we're going to save a lot of lives. I think it's exciting.
It was very exciting when I first got into this. Joel actually made that comment to me. Just think how many patients you're going to save with this. And honestly, now looking at our literature, I really believe that that's been accomplished. And I'm very excited to see this course take off and other centers be able to do the same thing as my panelists have done. Final approach would be, if someone wanted more information about this, is there a website or someplace else they could look?
Yeah, so there's lots of ways to get in contact. You can find my name pretty easily on CTSnet. We've got a website, csu-als.com, and the APA CVS has plenty of information on it as well. We've actually got our already EACTS published guideline out there, so that's freely downloadable as well, and there's lots of resources. So yeah, get in contact and make a difference.
All right, well, thank you so much. I'm thrilled to be joined with my panelists, Joel, John, David. Thank you much for joining me today, and we're happy to be here today from San Diego. Thank you.